A few questions to get us started. So first for Jean, there's undoubtedly an escalating discussion occurring nationally about the critical importance of diversion in this conversation, and it's certainly been highlighted on the panel just now. When you think about the diversion work you've been doing in Missouri, what would be the value of a more robust community resource, like a certified community behavioral health clinic? What would be the value of that for your diversion work?
So the value of partnering is the expertise that comes with it. So prosecutors understand the system of criminal justice. They understand the laws that they have to wade through. They understand protection of defendants' rights are also part of their responsibilities. But they don't generally understand how to treat. It's not that certainly, it's just not part of what we're taught through law school, nor what we're taught as prosecutors trying to learn the job. So for us, it is pairing ourselves with people who are more expert in that field so we can be more successful. I can be more accountable then to my community for when someone doesn't do well in diversion. Something bad happens in diversion. Somebody usually has to account for that, and it's me. And so it's good to have a thoughtful, researched program that has some academic rigor behind it so that you can demonstrate that to your community that you've done all you could to try and put the best possible product out there.
Thank you. And for Mark, and I had the pleasure several months ago to visit with you and your colleagues and see your jail and the work that you've done to really develop robust mental health and substance use services within the jail. And when you look ahead and think about the potential of there being a CCBHC in your community, how do you see that impacting your jail census? And when you think about those sort of initial steps of developing the partnership, as Jean describes, what are sort of the key things that you need to connect the dots on with the community research with a CCBHC to sort of bring down your jail census?
Okay, yeah, and that's the key, is reducing our jail census, reducing the amount of people that come into jail that reoffend, and that goes to the initial part, the assessment. Like I said, we kind of have a robust substance abuse and mental health areas inside the jail. It's when it's getting them to before they come in. So I really do believe that CCBHC would be beneficial to keep, especially the first-time offenders, mental health people coming in, streamlining the process, getting them the resources that they need, because we continuously see people coming in for very minor charges that have mental health issues, coming in, like you mentioned, urinating in public and trespassing and these sort of things. Getting them the resources, getting them on medication, getting the substance abuse help that they need prior to them coming into the jail, even resources to get them jobs and those sort of things, preventing that initial contact with the jail.
Thank you. Bob, you spoke quite a bit in your initial comments about the potential of CCBHCs through the added financing to really help you as a service provider to provide better care for the population and help connect dots and develop partnerships. So when you're thinking of this potential of being a CCBHC someday, how are you seeing sort of your better ability to connect with the justice system in Newark? And are there still continued gap areas that you see that we need to work on?
Sure. Thank you for the question. One of the things we do a lot of training in regards to CIT. We've worked with 15 of the 21 police departments in Essex County to provide training in CIT. And when we do those trainings and develop relationships with the officers and build relationships with the residents in their town who happen to be mentally ill, what's not generally known is the arresting officer has a lot of discretion upon contact with the individual. And if the arresting officer is aware that the individual has a severe and persistent mental illness, and furthermore, they're enrolled in our services, they would prefer, as long as it's not too heavy a charge, they would prefer to bring them to us, as long as we can provide the service and stop whatever behavior that was happening from happening. They don't want to go through the booking process and have to appear in court and yada, yada, yada. They'd prefer to bring that individual to us. We can only, given the current funding schemes, we can only do that in a very limited fashion. So anything that would allow us to create a more robust ability to do that type of basic thing at the street level, I think would benefit everyone involved.
Thank you. And Carson, we know, there's so many examples around the country of drug courts and community behavioral health organizations currently collaborating. There's great examples of this. What are the sort of additional sort of added services or resources that you would think that drug courts could really find useful from a CCBHC in the future?
When you're talking about somebody in a drug court, you're often talking about somebody who is the farthest down the continuum. So you're talking about somebody who needs all kinds of services. It's interesting. I can remember years ago, and I don't get this question anymore, but it wasn't unusual years ago for folks to say, well, can we really deal with folks in our drug court who have mental health issues? We're dealing with addicted people. And of course, y'all can appreciate the conversation that followed that. But just having the basic education. So many folks who, I always get the statistics wrong, but it's something like, and y'all probably know them better than me, for every person in the 50 or 50-something% of people in the justice system who the primary issue is mental illness, also have a serious substance abuse problem. And 70-something% of people with substance abuse problems have a diagnosable mental illness. There's no way you can separate the populations. That's just part of it. So having one thing that drug courts do and try to do really well is to have wraparound services. Because they recognize that if you bring someone in, if I come into your drug court and I present with 8 major issues and you solve one, and you put me out on the street, I still have 7 other issues that more likely than not will bring me back into the justice system. And a drug court's only successful if you don't come back into the justice system. And so they recognize they have to deal with a host of issues. So to have resources in the community that can assist that team of people deal with a host of issues with the folks they're working with is fantastic. It's a great resource. I can't tell you how many courts we work with, and there are courts that have behavioral health centers they can work with, and there's so many courts that are struggling to find even basic resources. They're struggling. They might want to take in seriously mentally ill people, but they don't have anywhere in their community. They just don't have the resources. They don't have it. They're searching for answers. They're searching for what the answer is. So I can think of a host of reasons, just the availability of resources, because there are places that it's amazing to me when I see what courts have done, and maybe it's because, and I think a big part of it is because if you have the leverage of elected officials, like if a judge or an elected DA say to do something, oftentimes it'll get done faster than if someone else says to do it. And so I've seen drug courts in very rural communities be able to harness resources that you would not think possible, because the judge has said, we are going to help these people, and it happens. But if you don't have that kind of leadership, or you don't have a drug court, you might not see that. But there are still, in many jurisdictions, where judges say that, and they can't make it happen. You can't squeeze blood from the turnip. There aren't the resources there. And I've seen courts struggle. They really do. They struggle with capacity. I think that one thing a lot of folks don't know, I think Roy Austin mentioned 2.2 to 2.3 million people behind bars in the United States. We have the highest rate of incarceration, I think, pretty much in the world. There was a study that was commissioned by the Justice Department that the Urban Institute did 5 years ago that showed that of those 2.2, 2.3 million people who were behind bars, 1.2 million of them would have been eligible and have been able to take advantage of a drug court had it been available in their communities. And as we look to reduce prison populations and then to also not fill beds that come empty, we have to find where are those resources to deal with these folks. Because there's still going to be a core of people who need those services. And when you have all these thousands of teams and drug courts working across the country trying to do the best that they can do, and they need all these available services, it would be a shame to tell them, we simply can't offer you the services. You're willing to do this work, you're willing to stick with these folks for months and years and to keep them out of prison, but we simply don't have the services. We simply can't help you. And that would be the biggest shame.
Thank you very much. Let's open it up to the audience for questions. Great. Let's start in the back there. Is a question?
Hi, thanks. Thanks, everybody, for participating. I'm Eric Roskis. I'm a forensic psychiatrist. I work in the Maryland forensic system. I worked in the Maryland correctional system. I've worked with courts and law enforcement. I think you started with the slide of the sequential intercept model, which is a really useful paradigm, and it's really complex. And I think what we didn't see is the complexity of our care system. We've talked a little bit about that today. In Maryland, we're working very hard to integrate our mental health and addiction programs. We've technically integrated at the state level, but at the line level, it's not so easy. And part of the problem with integration, as I've seen us try to struggle with this, is medical practice is a lot more complicated than it was 50 years ago. So if I'm a psychiatrist, I have to learn a lot of stuff to do psychiatry. By the way, in Maryland at least, doctors do have to do substance abuse education. It's very complex. As an internist, it's hard for me to understand how an internist can do all of internal medicine nowadays, frankly. So integration is really hard because it's hard for any one person to be integrated. The converse of that, of course, is if we don't integrate our care system, we leave the responsibility for integrating the care in the hands of maybe the person least capable of doing the integrating, the client or the consumer. So a big part of what we've done in Maryland is to integrate our work with the work of our consumer peer providers, whatever we want to call them, people with lived experience. I work very closely with our statewide consumer network. We have a state Office of Consumer Affairs, and we work very closely with them. We have certified peer specialists. We're working on developing forensic certified peer specialist programs. So to me, that's where the rubber hits the road, because if you're the person with those 8 problems, you are integrating them, one well or not well, but you are integrating them because you are the person with the problems. And so how that person can navigate the various systems that have to be navigated, some of which may be integrated, others of which not so much, that's where the work gets done. So I'm not the expert in that. It's the person who's been there that's the expert in that. For us, and we need to be able to recognize that. We need to be able to translate that recognition to our criminal justice partners who may not be as comfortable with the idea of people with lived experience becoming part of our care system. So that's a comment. I don't know that that's a question particularly, but that's all I have to say.
Any quick reactions from the panel?
I was stunned, and I totally agree with you. I was stunned. I remember, gosh, it's probably been 17 years ago, and I'm not going to call them out because they're not here, but Mecklenburg County, Charlotte, North Carolina, was doing a study. So they were starting with drug court. They had other systems they were trying, and it was very much what you said, and I think this is something we all lose sight of. They started offering, I guess what it was bus tokens, because they had a very robust public transit system, and they said, oh, we're going to offer all these services, and people can't make it, so what we're going to do in our programs is we're going to actually give out free bus tokens, and everyone will be able to go to the services. And then nobody was using them, and they didn't know why anybody was using them, so they had to dig down to find out, and they couldn't figure it out. And so it was actually somebody in the drug court, it was a friend of mine who was a prosecutor, went to the office, which was the public transit office, to do whatever interchange you had to do to get the bus tokens, and they handed him a document that was a 10-page thing to fill out. He could not figure out how to answer the questions. So finally, he told the people at the desk who he was and why he was there. They brought him in behind the counter and took him back and walked him through it to fill out the questionnaire. And he realized all these folks they're sending down here to get these free bus tokens will never be able to navigate this system. And what we've seen in drug courts throughout the years is case management is one of the key pieces, because you have to work, you're navigating way too many systems. And I've often heard this analogy made, and I think it's a powerful analogy. The medical system and the justice system for folks who come in are very similar. They're a black box in the sense that you don't understand it. The people in them are highly educated and highly professionalized, but when we're in those systems, we are at what? The most vulnerable point we will ever be in our entire life. And we just don't understand it. And so I think that having that case manager there to help navigate those systems is great, because that gives the person an advocate. And so again, it goes back to having all the resources that you can possibly have to help the people, but then we can't overlook having the resources is one thing, but just telling someone, hey, if you go down the street or if you go across town, X is available is different. Actually helping them get there, following up with them, identifying it. Did you go? Was there a problem? What happened? How can we help you? Is a constant piece of that.
And I think the other thing that case management does, and the gentle lady addressed it this morning in regards to accountability of the woman with life experience, case management holds the system accountable, because the system now knows that this individual who's coming out of the jail system, or we're preventing from going into the jail system, has an advocate, someone who's watching on their behalf, who will assist them in navigating the system. What you may not be aware of is the mental health system and the addiction system, we count on no-shows. We manage for no-shows because we don't have the resources to provide the services to everyone. And in fact, if everyone that needed the service and was scheduled to get the service actually showed up, the system would crumble. It's so overburdened and underfinanced. So the Excellence in Mental Health Act can have a major impact on that, so we can do a better job of holding ourselves accountable, because we're more likely to be accountable with the resources. Another thing I like to say about accountability is, unless there's a differential rate to provide the services to this population, the system, and it's human nature, it will absolutely happen. The system will drift to serve the people that are easier to serve. That's the human condition. You can count on it. So if we want to make real progress here, there needs to be a differential case rate for the more involved clientele that are more challenging. Because if an agency is going to get paid the same $45 for a half hour, no matter who they serve, it's not going to be a conspiracy. It's going to happen naturally. They're going to end up serving the easier people to serve.
Yes, front of the room here, Steve.
I want to try to ask this question with as much politeness as I can manage, which is generally not my strong suit. At Cochs, we've been very good at understanding the worlds of our friends in public safety and getting to visit with them a lot. And one of the things we've understood is that our friends in public safety are not the best purchasers in the world of non-public safety services. And I think the question I would like to ask the panel is, does having a certified community behavioral health center, separate from all the service and other wonderful things you all have been talking about, would it make you guys better purchasers? Because one of the ways that we have to bridge the gap between the justice system and the health system is making the justice system a better purchaser of health and behavioral health services, which quite frankly, it's not at the moment. So I wonder if all of you could comment on that, please.
I guess I'll start. That's the idea of being a good purchaser or a bad purchaser sometimes has to do with that horrible word politics, that there are some people, some agencies, or some groups that get, they seem to get, they're the first in line to get selected for a new county service because they're regular contractors. So I would say that it's one thing that happens at a local county government level. So the more legitimized this type of process could be, and that the services can be, of course, you know, I mean, folks like me are going to lean on what I believe is to be the best product. Sometimes the cost of that does matter. I have to articulate the value for the cost. But if there is, I think I used the word academic rigor behind it, if there's some research behind it, if some folks in the mental health profession, frankly, could be better politicians in articulating why this service is needed, why it is a cost saver over time. Those are all really important factors in forging that relationship.
Yeah, it does. Politics does play a huge part in it. You do have to sell the product, and I am definitely for it. It definitely would. I mean, CC's BHC would definitely help our, especially our diversion stuff and streamlining things and dealing with so many different stakeholders. But that is the key is being able to sell it to, whether it's our county board or state legislators and that sort of thing to, for the funds and that sort of thing to move that forward.
Any other questions from the audience? Yes, front here.
Hi. I was wondering if, I know we have a robust probationary program, and I was wondering if anybody ever thought about our reporting mechanism, the way that every single one of these agencies, regardless of whether they're in the correctional facility, educational facility, or, health facility, if the mechanism for reporting was standardized, and, I know in Florida we have something called a Daubert hearing, so that, when a decision is made about the rigor or the scientific rigor of an opinion of a scientist, it has to actually be proven. And so if we elevated the rigor to ensure, that this reporting mechanism met those standards, if all of these agencies could report together to be able to, maintain or glean some interoperability, because, we know that in drug court, you were mentioning about the holistic approach and looking at the other 7 services that are needed to reduce the rate of recidivism. But if the mechanism for reporting could possibly be the mechanism for treatment, how about, what would that entail to be able to have a centralized reporting so that we actually do gain interoperability, so that in between these silos, that we can actually break them? Because what I'm looking at and what I notice is a repetition of the same program in a different, version. But what I don't see is the communication of those best practices. So whether it's, the best practices in Kansas City versus, in New Jersey, which ones actually work, and that goes to accountability. If we insist that our purchasers actually ensure that whatever they are purchasing has a bottom deck for scientific rigor that's already been established by CMS, if that would be able to help.
Well, I guess I can try and respond to that. One of the things that we have done in Kansas City is that we have paired ourselves with an academic partner on new programs so that we can be studied, we can be evaluated. They really, truly are a neutral party. And so what they produce for us is, especially in my mind, it is a trusted result. So they're going to, sort of help me modify my program. As I tell them, they teach to the test a little bit, so I know how, where to make modifications and how to do a better job. But the whole idea of sort of streamlining or standardizing something does make me a little bit concerned, because we are talking about human beings, and we've talked a great deal about case management, which I learned is critical, absolutely critical. So you can't just, courts are notorious for giving an offender a card, little really, very little card that gives them their next court date or gives them where they're supposed to go to report, for something or another. And that doesn't work so well. So what we've learned is in order to get people to respond and show up on the date that they're supposed to, we got to give them a ride. We have to go down to transit and make sure that they don't have issues, receiving that service that we told them to go get. So it's expensive. It is expensive because I've actually had to buy cars for the case managers to actually pick people up and take them, to their next appointment. But if you want the outcome, then these are additional steps you have to take. And so I guess the piece I wouldn't want to lose there is the human intelligence, what my case managers have to tell me and what we glean from treating individuals versus systems.
And if I could talk a little bit about evidence-based practices, who doesn't like evidence-based practices? What's not to like? But I'll tell you this, you can have the greatest models in the world. If you don't have the charisma behind it, well-trained staff that believe in what they're doing, it'll fall flat. The Mental Health Association of Essex County, we have a housing first model. It's our philosophy. I believe in it. The staff believe in it. The board believes in it. We have the research to back it up. But what really makes it go is this gentleman named Ross Cressman, who's a 35-year-old social worker who lives and breathes what he does. And he believes in it, and he encourages his staff to do the same thing. So it's the human capital that makes the difference in the models. Models are all well and good, but it's the human capital at the end of the day that makes the difference.
If I could just add before we move on to the next questioner that it hasn't been much of a topic of discussion at today's meeting, but there are robust sort of quality and measure reporting expectations for CCBHCs. And the topic of the next panel, health information technology, and particularly electronic health records, is fundamental to that discussion. The ability to be able to collect and report out the data to really identify and clarify the value of the non-four walls model in this new demonstration program will be key for accountability. Sorry about that, please.
Hi, I'm Linda Elam with Department of Health and Human Services, and it's been a great panel. Thank you. I have a lot to take away, and great day, so thanks for that too. A couple of specific questions though for Jean. You mentioned the increasing impact of having a felony on somebody's life, and I was wondering if you could talk a little bit more about why that is and what could be done about it. And for Robert, I'm really struggling with the idea that people are sicker in corrections than they are in inpatient hospitalization, and trying to connect a number of dots on how that could be. And so if you could help explain that a little bit as well, I'd be very happy. Thanks.
The impact of a felony, I think a felony conviction, in the criminal justice system, we like to think there are grades of, you sort of have a felony, but it's only for certain purposes. And then, you graduate up to a felony that maybe more of the world gets to see. And then there's the part where, your sentence is actually executed and you have to go to the Department of Corrections and serve whatever percentage of time you have before you come out. Once upon a time, grade 1 was just not known largely by the world, and most of the time, employers didn't ask about that. Somewhere along the way that changed. I think one of the ways it changed is just quite simply with technology. Now I can look up, I can Google you, you can Google me. You can probably learn a lot of things about each other just by doing that. And then we have, even though we do seem to say one thing, we practice another. What I mean by that is we say that once someone has paid their debt back to society, that they've served their time and they are now released, that they should get to stand on the same soil as everyone else, that they are on the same footing. But we all know that's not true, because when you go apply for a job, it's the very first time they're going to tell you, oh, but not you. I'll take the next guy. And so the biggest challenge that I see is how a felony conviction stands in the way of real job employment opportunities. The other piece that I did want to put out there is, there's been a discussion about drugs, and drugs being one of the reasons that is pointed to for mass incarceration. I don't know that I believe that to be true in my local jurisdiction. Maybe I think that because we were one of the first in the nation to establish a drug court. Our drug court is very robust, and it's just part of our vernacular. It's just who we are, and is always has been, not always, but almost always now. But drugs are just part of it. I think I was speaking to someone at dinner last night that somewhere along the way I looked at when I became prosecutor, filing criminal charges for failing to pay your child support. And I thought, boy, that seems dumb. Why are we doing that? Do we have another way? And so we found another way to go about that without putting the felony charge on someone to try and get compliance. Another thing I learned when I quit filing those criminal non-support charges was that a lot of guys who had child support matters were also having driving records that were a horrendous mess, because one of the systems put in place was if you are not paying your child support, the state can remove your driving privileges. Well, folks keep driving. They get stopped by police, and so now they have a whole nother series of issues, which is driving while your license is suspended or revoked. We were filing those cases in pretty large quantity. So, I mean, all of us are responsible to sort of sit down and look at our systems and ask ourselves, does that make sense? Why are we doing that? Is there another way to go? Can we restore this guy or gal's ability to get a job, pay their child support, and be able to drive to their job? All of these systems were put in place to deal with very real issues, but sometimes they don't work.
So how do people end up in jail and oftentimes are sicker than the people in a psychiatric hospital? Well, the following happens. An individual will go to the psychiatric hospital, maybe by themselves, maybe with a family member, maybe with one of our case managers at the Mental Health Association of Essex County, because the underfunded mental health system wasn't enough for this particular person. Or, and this is important, the person suffers from schizophrenia and despite our best efforts, decompensated anyway. Ladies and gentlemen, that happens. I'm all about wellness and recovery, living in the community, people getting better. I believe in that. I spent my life doing it. But some people get sick despite our best efforts, and they will continue to get sick even with the Excellence Act, despite our best efforts. So we bring this individual, or an individual goes to the hospital, they present themselves. 9 out of 10 times they're not going to be admitted. 9 out of 10 times when they are admitted, they'll be discharged, in my judgment, too soon. That cycle repeats itself and repeats itself and repeats itself. And eventually, the person will do something to bring themselves to the attention of law enforcement. And while there's a 2 to 5 day wait in emergency rooms in New Jersey to get into a psychiatric bed, you can get in the county jail right away. There's always room at the inn with the county jail. So the person has an easier time accessing the county jail than they do our psychiatric system. And I invite you to do the exercise that I opened up with. Go see it for yourself.
I have a follow-up question for Bob. What is source of funding, Bob? You indicated you're funded by the state, but you weren't specific about general revenue dollars, Medicaid dollars, some combination.
Yeah, our jail diversion program, it's about I want to say $800,000 program. I'd say $500,000 of it comes in a direct grant from the state, and we build another $300,000 through targeted case management, the Medicaid program.
And then replicability, what about the other 20 counties? What are they doing?
Pardon?
What about the other 20 counties? Do they have similar programs?
Well, some, I would say half the counties have nothing.
Right, that's what I'm
And, the other half the counties are doing what this gentleman's doing, being as creative and innovative as they can, and they have some version of what we're doing. The Attorney General just got involved, and the last couple of years he had 2 pilot projects in terms of the prosecutor's diversion, and he just increased that to 5. So he's added 3 more counties. And the Supreme Court, the Chief Justice, has also been very interested, and he has a committee as well that's working on these issues. So there is a head of steam building in New Jersey around this issue. So if we can get this act passed, I think it would make a big difference. Because people, for the first time in my career, want to engage. I used to have to knock on their door. Now they're knocking on my door.
Thank you.
One more question in the back, and then we'll have to wrap up.
Hi, my name is Kendra. I'm from the White House Office of National Drug Control Policy, and I have a question for you guys. I am in the treatment branch in the Office of Demand Reduction, and we struggle a lot with trying to get drug courts to offer medication-assisted treatment. I feel that we can't, as a whole, say that we want the best for people, and we don't have drug courts offer any treatment that is specialized to the individual. People need different types of treatment, so what would your suggestions be about that? We're trying to educate as much as possible, but it's hard.
Well, that's probably a question for me. I mentioned our best practice standards a few minutes ago, and we have a standard on evidence-based treatment, and the standard actually talks about medically assisted treatment. And you may not know this, but we actually are working with the White House now, ONDCP, on a project to do a national curriculum for drug courts that's basically a toolkit on how to. Because one thing that you find, and drug courts aren't unique in this, if you tell someone to do something but don't give them the tools. So we're actually working together right now to provide a toolkit. That'll be a written toolkit and a webinar that will actually assist with that. Because I think that a lot of the times in drug courts, and again, in other areas of practice, telling someone to do something is different than showing them how. And so we're going to help show people how to do it. But I mean, it's a great question. One thing so we have our best practice standards, mention it, and someone in the system in a drug court is actually much more likely to get access to medically assisted treatment than in other places, because drug courts tend to be overall very savvy about that, but there still is a how-to piece.
Please join me in thanking our panel.